started to respect all of your time today. My name is Tracy Cleary, and I'm an Outreach Education Manager for Eagle Med. My main area is the western half of Kansas, and so hello to all of my soon-to-be new friends again out there. I'm anxious to come see you. Today we're going to be presenting some information on capnography. Go ahead and Mike, next slide. We really do hope that you guys all had a wonderful EMS week. We were able to launch our first online education with landing zone safety during EMS week. So that was a lot of fun for us and being able to talk to you all. So we hope that it went well and we'll continue to celebrate you throughout the year. A few housekeeping things. So for EMS providers, especially those in Kansas, we will need you to check in every 15 minutes. So there are three different things here that you're seeing of where you can find the chat box. On the far right, for those of you viewing on the phone today, your chat box will be in the top right-hand corner. And then for those of you on the desktop, you should be able to move around in the middle portion and find your chat boxes there. If you do not, Mike, if you'll do one more click, if you do not have a chat box, I will need you to text me at this phone number and I will put that into the chat box every time that we do this, every 15 minutes. You'll need to text me though to make sure that I can count you for the 15 minutes. Evaluations and CEUs we'll talk about again and you'll get another email, but you will be sent an evaluation link this afternoon. You'll also be able to access it after the presentation's done today. Those evaluations will need to be done by 6 p.m. this Friday. And then your CEUs, I will have, each of you will receive a certificate in your email that you provided on your registration. And then for your Kansas EMS providers, you will all be put into the portal by myself. And so you won't have to worry about any of that. And you'll be notified when all of that is done. Next slide, please, Mike. And you can go ahead and click it through those. There you go. Very good. Just another little overview of everything that we have going on here as global medical response here in Kansas. Again, this is the air side. And then with our ground units, and then we have our sister company of AMR in the Kansas City, Topeka, Lynn County areas. So that is how we all kind of mesh together. If you hear us just say global medical response, it includes our 2 rotor wings in Midwest Aero Care in Chanute and Pittsburgh. And then next slide, it also includes our 3 rotor wings in Kansas City, Junction City, and Lawrence with 5-Star of Kansas. And then last but certainly not least, our 2 rotor wings, in Hayes and Wichita. And then our 4 fixed wings in Goodland, Dodge, Liberal, and Wichita. So that is kind of how we all mesh together. We all are CAMES accredited also, so a huge accomplishment by all 3 flight services that we are very, very proud of. All right, one more. Your learning objectives today, Mike will go through each of these with you, and then at the end, we're going to have another slide that basically asks you, did we accomplish everything we set out to accomplish? And then one next slide, please. And without further ado, I get to introduce Mike Wallace. He is also an Outreach Education Manager for both the 5-Star of Kansas space area coverages and Midwest Aero Care. So Mike pretty much has the eastern half of the state, a very experienced provider and educator, and so we are very glad to have him on board. And I'm sure those of you in the eastern half of the state would agree that he's a welcome face to have with education and very intelligent individual. So, Mike, it is all yours.
Thank you. Can you hear me?
We sure can.
Okay, awesome. Great. Hey, thank you all for taking time out of your day today to do this presentation or sit through this presentation. I'm going to be honest with you. I like being in front of the class and seeing faces and exchanging information and ideas and concepts. So this is actually kind of a first for me when it comes to talking to my computer screen. So, you know, if you have any questions during this presentation, feel free to put them in the chat box. Speaking with Tracy in regards to that process, if there's something that's really a dire question, then she'll find an appropriate time to ask that question. Otherwise, what we've kind of agreed to do is at the end of the presentation, we're going to assemble all of the questions and kind of put together a frequently asked question type thing with answers. And then you will get that with your survey or your evaluation. So we'll just kind of play that as we move through this process. So as far as disclosures are concerned, the only thing I really have is that I am an educator specifically for waveform capnography for Medtronic. I've been actually teaching for them as a contract instructor. And if you don't recognize that city, that is actually San Diego. So one of the cool things about Medtronic's outreach is 4 of us actually spent a month in San Diego teaching the entire San Diego Fire Department waveform capnography. So we had a great time, got to do some ride-alongs and all of that. So pretty good time. So to kind of get into this this discussion here, I kind of want to pose a couple of questions to you. Is does your organization utilize capnography in patient care right now? And as you kind of entertain that question, you know, obviously some of you are going to say yes, and it may be in a very wide view where you use it on all spontaneous breathing patients, and yet a significant majority of you may say, yeah, we pretty much utilize this technology in intubated patients only. Also, you may say, no, our department doesn't utilize capnography right now for whatever reason, but yet we may be looking into utilizing that technology in the future. I find all of these answers to this question, all of those answers to these questions as I travel around and get to talk to people about this wonderful technology. The second thing to ponder then is how much initial or ongoing training did or do you receive when it comes to capnography? And there's where the great disparity does exist. Some people say, hey, next thing I know, it was put on the inventory, it was put in the ambulance, and we really didn't receive any training, and yet others received pretty significant training for capnography. So EMS1 did a poll, and it kind of asked, how do you use capnography in your particular practices? And it was a 2015 survey, but they had a pretty good response with it. And what's interesting is when you look at this, you know, capnography is easy to use, it's easy to interpret, and all of those things. For us, a majority of the people agreed or strongly agreed to that. And then when you kind of break it down into how was it utilized, a majority of them said that they strongly agree or agreed that they used it in that spontaneous breathing patient. Before we go any further, if you can, go ahead and mute your microphones, if you would, please. And that way we can not hear all the other noises going on. So, but what about capnography training itself? So let's look at what they found out. And when you look at this one, it says how many hours of capnography related training, self-study, etc. You can see 7% had no training, as I said before. And I can relate to that because some of the small departments that I have the privilege of going to, they really lack that training component, yet the technology is there. And then you can see the average is about 2 to 5 hours with training. Now, this is just the initial training and not necessarily ongoing training. So you can just kind of look at your organization and see, where do you fit? You know, where does this fit for you for initial training and continued? Now, this is kind of a cool slide, and this really kind of shows that more people are jumping on the bandwagon of capnography, and they're starting to think outside of the box as to the other types of ways to utilize this technology. And overwhelmingly, and of course, AHA drives this, you know, through our ACLS and our PALS and all of those things that they talk about in cardiac arrest, the importance of utilizing waveform capnography. And then certainly, of course, spontaneous breathing patients, respiratory rest patients, dyspneic patients, about 93%. What I think is cool is when you look at the trends when it's happening towards sepsis. And we're going to talk in this presentation about the correlation between waveform capnography and a patient's lactate, that relationship there that does exist. So more patients are starting to utilize this, whether they realize the connection or not, for septic patients. And then, of course, traumatic injury. I don't know if this specifically traumatic injury, if this is all incomers as far as traumatic brain injury, including multi-systems trauma, etc. But for trauma, it's being used as well. What we'd like to see is these numbers to significantly go up, which is hopefully a reason why you're here today to become more comfortable with this. This is also very cool. Capnography is the most effective method for confirming airway placement, and of course 56% strongly agree. So you can see how the rest of the respondents actually kind of fall out with that. So, and again, a lot of that is driven by what it is that we are, that we hear through not only our personal learning, but through our certification programs. So my goal with this program, spending the next few minutes with you all, is to hopefully make you feel more comfortable with capnography. So whether this is going to be your first initial exposure to it and a kickoff, if you will, and I know we've got some organizations that are actually watching this program right now as their initial. We've got a nice response with the nursing staff from various facilities are watching right now. So my goal is that you not only feel more comfortable with this, but you become more passionate about utilizing this technology that's there. And whether this is your first class in capnography or your 15th or 16th, I hope that you find some sort of a golden nugget of education that you can kind of put in your pocket, and that way you can utilize that when you have your next patient. So with that said, let's kind of start off with a case study. Now, you're evaluating a 41-year-old male patient with a complaint of chest pain, and he rates the pain at an 8 and had an onset times 45 minutes ago while at rest. So nothing makes the pain better or worse, and it radiates into his right shoulder. So this patient has no medical history, takes no medications, has no known drug allergies, and the vitals are there in front of you. Patient appears to be cool, diaphoretic, and pale. So my question to you then is, what else do you want? And so as we kind of think about that, and I think what's screaming in everybody's mind is hey, we want a 12 lead, right? 12 lead is the standard of care. We have performance measures that the minute we suspect some sort of chest pain that we're held to. And so we want to get that 12 lead. So let's take a look with this patient, what we have. So as this thing pops up on your screen, you're going, ruh-roh. And my question is, anything stand out to you? So I think everybody in this room identifies the significant global ST elevation. This is obviously a time-critical diagnosis, etc. You didn't need to read the interpretation to see the acute MI there. So some follow-up questions to this is this a life-threatening emergency? And of course, we're all like, yeah, why is he asking this question? It's a time-critical diagnosis. So what should we do with this patient? Well, obviously, we need to get the patient to a cath lab as quick as we can. And then what led us to the decision? Well, we know with chest pain patients, what makes the decision on whether a patient goes to the cath lab, etc., is that 12 lead. So with that, let's change gears just a little bit and look at another case. So in this case, you're evaluating a 41-year-old male patient who is experiencing difficulty breathing. As you note, the patient's only speaking in 1 or 2 word bursts and has increased expiratory phase with increased work of breathing. So this patient's really, really working hard to breathe. Breath sounds are diminished with expiratory wheezes that are noted. And as you gather the history, the patient does have a history of asthma. Has no known drug allergies, and of course there are the vitals. Noted SAT of 96%. So what else do you want? Again, what is the treatment? So here's where this may vary. Some of you say, well, let's go ahead and get capnography on. Let's get a line. Let's get a 12 lead. Let's start an albuterol treatment. Let's get some steroids on board. Let's consider CPAP. All these things that come out. But specifically, let's talk about capnography. So is capnography useful in this patient? And many of you are going, absolutely. So when we place the patient on waveform capnography, this is what we see. So what does this show us? Well, I would argue that this shows us just as much information to the severity of the disease process that does that previous 12 lead for that MI patient. And so when we look at this capnogram, it does show us that truly this is a life-threatening emergency. We already gathered that, and that this patient is significantly at risk for respiratory arrest. But when we talk about where is this patient in this asthma attack, is this patient in an early phase of asthma? Is this patient past that and into a late stage of asthma? We're going to talk about that, where this patient lies in that, and where the concerns are when this gets to this particular point with this with this patient. So what is capnography? Where did it come from? So the Greeks believed, Greek mythology, they believed that the body had a central combustion center. And they noticed that on cool days, cold days, where they could see their breath, and they called that byproduct or that smoke, they called that capnos. Capnos is Greek for smoke. So there's the originality of that. So we now know this combustion center to be that as of metabolism, and that smoke of that metabolism, of course, is CO2 that is, of course, measurable. So that kind of gives you an idea of where that term has come from and what it means. So what are we measuring with this? I will argue that if you can take these next 3 slides and you can really understand globally these 3 slides, you will understand capnography, you will understand the benefits of it, as well as where we can run into some problems with it. And so what we are measuring is that we are measuring perfusion, okay? We are measuring blood going round and around. We are measuring oxygen and CO2 exchange. We are measuring that CO2 as it is offloaded at the alveoli level. So the better perfusion that we have to the lungs, the more blood flow that engulf that circulate the alveoli, the more we have that exchange of CO2 out, and it's measurable. When perfusion is down to the lungs, such as shock, such as cardiac arrest, we're not going to have that exchange of gas readily occurring. Therefore, perfusion is down and our CO2 will be down. So in normal perfusion status, that's what we're measuring, okay? I also like to think of it this way for my fire department friends out there. You know, we love, well, I don't want to say we love this, but you know, you roll up and you roll out of the station and you look and you see that big smoke cloud and you see how dark it is and all that. You're thinking, yes, we've got a pretty significant fire here. So in this particular case, that smoke being the CO2 is the byproduct of that metabolism, or that burning process, and that's what's happening at the cell level that is exchanged off. So the bigger the fire, the more smoke. The smaller the fire, the less smoke that we have. The second thing to take into consideration when we are looking at a capnogram is that we're looking at airway patency. Now we're going to talk about how there's only one normal capnogram, and that's cool. I mean, it's not like you got to learn 50,000 different EKG strips and all of that. The cool thing is that when we see a normal capnogram, that's it. And when we have that normal capnogram, which we'll go over, we are seeing airway patency from the alveoli to the adapter on the side stream or mainstream adapter for the capnography. So when you have patients who have respiratory issues, they're having an asthma attack, obviously they're going to have some restrictions in that airway, and that's going to be reflected in our capnogram itself. So again, you are seeing perfusion to the lungs, and you're seeing airway patency. And those two things are important to understand globally as we move forward with capnography. So waveform capnography. So waveform capnography is defined as the continuous measurement and display of carbon dioxide in each exhaled breath. And that's important to understand because it is a breath by breath snapshot. It's a breath by breath picture of airway patency and perfusion. Okay, and so as we look at that, as we squeeze that bag and we're ventilating that patient from a positive pressure standpoint, or we're watching them exhale their breath and we're watching that capnogram, what that can show us is it can show us how well they're doing metabolically, cardiovascularly, and their respiratory status. And we're going to really tie all this stuff in at the end of this with some cases that I think are going to make more sense and hopefully tie this in to make you feel a little bit more comfortable. Waveform capnography, when we get that breath by breath picture of that exhaled CO2, we call that the measurement of ventilation, that process of ventilation. So here's another way to kind of take a look at this process. And I got 2 slides. Yes.
Okay, just real fast, the check in here. that we put the poll up, and that's how we tell you to check in, is every 15 minutes there'll be a poll. If it's not letting you answer in the poll, that's not a big deal. Just go ahead and just type your name or I'm here. But you guys are doing great, or just text me if you don't get that. It's not a big deal at all. This is just a short check-in, but the poll is available and up in your chat box to do that. Thank you.
Tell me when to continue.
You may continue.
I don't want to start until you tell me. Okay. All right. So there's only a couple of physiology slides here because, well, just because. And so really when we think about this in normal perfusion at the cellular level, we use O2 consumption. You have a CO2 byproduct or CO2 production at the cells. And that's in normal aerobic metabolism. So as those cells are using that, consuming the O2 and they're producing the CO2, that is transported by the heart, obviously, to the pulmonary capillaries. At that particular point, that's where the ventilation between the alveoli and the pulmonary capillaries exchange, and we have the CO2 that's released from the blood. O2 comes on, and we can pick that up in a capnogram here. So another way to kind of look at this, I think it's kind of cool, is that we have metabolism, that product of aerobic metabolism. CO2 is the byproduct. It's transported by the heart and obviously the vasculature in the blood, makes it to the alveoli, and it's off-gassed and it's picked up in the form of a capnogram and capnometry. Now you'll notice there's two types really of capnography or the way we measure. One of which is you'll see the numeric value only, that is capnometry, and then you'll see the actual waveform itself, and that is capnography. So you will see those referred to either way, so that's where they come. Capnometry is the number, capnography is the actual graph itself. And now you'll also hear it referred to as PETCO, which is pulmonary end-tidal CO2. So those are the kind of the three terms of how people talk about capnography. Now, because we have a metabolic type component, we kind of have a indirect measurement or look to the inside to what's going on from the metabolic standpoint. What I'm talking about that is a correlation that does exist between arterial CO2 and end-tidal CO2 values. Now, so your normal arterial CO2 values, or PaCO2, is generally about 35 to 45 in normal blood gases. So how that correlates, according to the studies, is that it can give us anywhere between an end-tidal CO2 between 30 and 43. So that kind of gives you that range. And there's a lot of different variances and things like that fit into this, that obviously there can be derangements with it, but overall the general idea and concept is this. So this is the kind of study that kind of looks at that offset, whether they're supine, lateral, prone, whatever, sitting, and the correlation. And down at the bottom there, it suggests the offset may be anywhere from 3 to 7 millimeters of mercury. So there are some benefits to that if you're kind of seeing, if you're trending that normal end-tidal CO2 range, which we like to say is 35 to 45. It can, in a normal perfusing patient, give you an idea of what their PaCO2 is as well. So our normal range, as we said before, is what we look at is between 35 and 45. And again, I want to reiterate this in a normal perfusing patient. So what about pulse ox? So here, this is the only war story that I'm going to tell. And that is when pulse ox first came out. And I know that there's some very experienced, I saw the list of people that are watching this course. And I know some of you are very, very experienced paramedics. And I know you remember when pulse ox came out. So for me, when I came out, it came out on a big old Nelcor single unit. You had the finger probe, just kind of like what you see here. And I loved going in, and I loved sticking it on the finger and having this Superman moment where you waited for it to clear and you went, boom, your pulse ox is 98%. Mr. Smith, you are doing great. And I remember those days and getting that false sense of security and everything that is there. But boy, do we learn. And we learn, this whole thing about this oxygen disassociation curve and things like that, where it talks about how well the hemoglobin wants to keep or give off the oxygen. And we can all, the O2 molecule. So there's lots of things that we can think about that make this pulse ox not as accurate as we really want it to be. And so, you know, that's the rationale, that's the reality to it. However, we do know that it is a powerful tool in the toolbox. So with pulse oximetry, it does give us a good picture of oxygenation in our patients. Now, the other part of that is then comes capnography. And with capnography, just as pulse ox looks at oxygenation, capnography in tandem can give us a good picture of ventilation. And I think that that's a pretty cool thing. So we want to move forward, making sure that these two things go together, that we're actually looking how well our patients are oxygenating and ventilating by using pulse ox and capnography. Now, in some other courses, and as I was putting this course together, I mean, there's obviously some things such as VQ or perfusion ventilation mismatch or VQ mismatches. And those are some things that we can cover in a face-to-face course. But for the purpose of this course today, I want to build you up with excitement with this, show you the power of this, and with some great case presentations and turn you loose. And we'll talk about some other things as we end this thing. So there are different tools that are out there that you can use to detect CO2. And this was the first ones that kind of came out, these pH sensitive chemical papers or colorimetric devices. And here, really, we're not looking at quantitative CO2 per se, we're looking at qualitative CO2. So that litmus paper in the middle is an acid, it's prone to acid, it changes color, and we know that CO2 is a weak acid, so that when it hits it, it turns the color, and you're looking for a yellow. So these are good, and these are still being used, but there are limitations. They're not necessarily reliable in cardiac arrest. They're not quantitative, so they don't give you a number. They don't give you, obviously, a waveform. And sensitivity, at least the best studies show in arrest patients, is about 69%. There's other things that can turn that litmus paper yellow. It's acids. You know, if you're given intratracheal medications, they can affect that as well. And so certainly newer technologies have become more affordable and, you know, obviously are significantly, I think, better. And that comes in the form of capnography and capnometry. Now, one thing I want to mention here is that I do go to some places, and this is really kind of a thought here, is that when I ask, you know, what are you using? Are you using the colorimetric or are you using capnography? And the answer in a lot of my places is that we use both. And it depends on where you are. And so, for example, in the surgery or surgical suite, and certainly post-surgical procedures, you're obviously getting end-tidal CO2 measured. Usually your CRNAs or anesthesiologists are doing that. However, if you get intubated in the emergency department, you get the colorimetric device. And so I always ask them, why the different standard of care then? If you utilize end-tidal CO2, capnometry / capnography in one area of the hospital, why isn't it in all of the areas of the hospital? If I'm getting intubated in the emergency department and somebody else is getting intubated in the surgical suite, why do I get a different standard of care? And we're going to talk about standard of care and how we're all held accountable when we talk just very briefly when it comes to medical legal at the very end of this thing. So some things to think about with the use of those devices. So capnography and capnometry, we already said, provides both that waveform and digital readout. Usually it's measured in millimeters of mercury. And there are two types of capnographs or technology that are utilized. And these are the two, side stream versus mainstream. Now, a majority of you utilize a side stream technology, and it's simply whether it's a nasal cannula adapter that's got a sampling tube or the adapter that goes around the endotracheal tube. It pulls a sample into the machine, and the machine gives you the end results, versus a mainstream, which has the source at the endotracheal tube, and you get your sampling. Both of these utilize infrared sources. And if you can think about it, if you look over on the left with the mainstream, you have the sensor, you got your infrared source that's actually sending the infrared beams through to the other side, which is your detector. As CO2 passes through the infrared sources, the infrared rays are actually absorbed in the CO2. So if you have a lot of CO2, you're going to have more absorption of those rays, and the infrared detector isn't going to pick up as much, versus less CO2, more is going to get through to the detector, and that's how that works. So if you have a lot of CO2, obviously you're going to get a higher response when it comes to what your CO2 values are. So that's how that technology works. Sampling devices, this isn't unfamiliar with any of you. You've got your patient point of contact, for your spontaneous breathing patients, sampling device there with a nasal cannula. And then of course you have your endotracheal tube sampling device as well. Again, both of these are demonstrating side stream technology. And one of the things that I like to do typically when we do face-to-face classes is to pull these things out, hook them up, have people breathe on them, have people hyperventilate, hold their breath, watch pulse oxes. There's all kinds of fun little things that we can do to kind of firm up this whole concept of capnography. But I do encourage you to pull these things out if you're going to do some continuous training or some continued training with this, that you actually get your hands on these things and start breathing on them and do some experiments with it. So. Right. So the next thing we're talking about is the capnogram. And as I mentioned before, there's only one normal, and you see it there on your right. Okay. So as I said before, it indicates the patency of your airway. So with a capnogram like this, I know that airway is patent from alveoli to the sampling tube. Where we start to have differences in the shape of it, for example, a shark fin, that indicates that there is a problem to the patency of that airway. And in that case, we generally associate shark fin type capnograms with restrictive airway or asthma type issues. So here we go. So let's just kind of go through this. So now remember, this capnogram is generated by the detection of the CO2. So that's on exhalation. And some people, they're looking at it and they're like, God, this, inhalation, exhalation. So no, you're looking at the exhalation of itself. So between phases A and B, this is where they begin to hit that process of exhalation. Now, really the air is starting to clear from our anatomical dead spaces, so you're not going to have any measurable CO2, but as we continue to exhale, that's when we start to get that mixed CO2 response, and then we start to get to our highest concentrations of CO2. So as we exhale, we enter into phase B. Now as we hit phase C, we're starting to get the most deep alveolar air, and that's where we get the highest concentration of CO2. Where you see D, where it says the end tidal CO2, that is the end of the exhalation process. And in fact, we begin to take a deep breath, or we begin to inhale, and that drives that down because we dilute, obviously, the CO2 very, very rapidly, and it returns down to baseline. So that is the process of the beginning of exhalation to the beginning of inhalation. And remember, when we talk about end tidal CO2, that's that maximum concentration before the inspiratory process, and that's signified on your screen there by the letter D. So when we look at capnograms, then there's a few things that we want to look at, these 5 characteristics. First of all, we want to look at the height. I want to know how high is that capnogram. And the height of that capnogram also is generally reflected in the capnometry number that you get. So the higher the CO2 value, or the higher the capnogram, the higher the CO2 value, and the lower the capnogram, the lower the CO2 value. And we'll talk about those specifically here in just a second. Frequency. Well, as you're looking at those capnograms, it gives you a great idea on what their rate of breathing is. As a matter of fact, if you're wondering how fast you're ventilating a patient with a bag valve mask, and in cardiac arrest, we like to use the rate of 6. Well, I can look at my monitor and see, because the monitor will give me my respiratory rate in conjunction with the capnograms that are on the screen. So it can kind of help me with my rate of breathing. Rhythm in a spontaneous patient, depending on the different types of breathing patterns that are there for DKA, head trauma, whatever it may be, I can pick up on those breathing patterns. So certainly some benefit to there. We'll talk about baseline as we talk about troubleshooting, but generally the capnogram should always return to baseline. And there are some situations that may exist where that doesn't happen. That's for a later time, but for the most part, it returns to baseline. And if it doesn't, you usually have some sort of an equipment or calibration error. And then, of course, the last thing, of course, is shape. Again, being normal versus some of the others that we're going to talk about. So again, we're going to look at height, frequency, rhythm, baseline, and shape as we look at these. So let's talk a moment about hyperventilation versus hypoventilation. And so you can see here we've got capnograms on both of those. And so you can see on the top one, this is an indication of hypoventilation where maybe I'm not using as much tidal volume, maybe I've decreased my respiratory rate, so I'm not breathing off as much CO2. So we know when we don't breathe that CO2 off, it's going to accumulate and my CO2 value is actually going to begin to go up. I can very simply correct this by increasing a little more tidal volume or increasing my rate, which will bring the CO2 value down. So that's a good benefit for that. And what I always like to think about, we talk about traumatic brain injury, and I know PHTLS talks about the use of capnography for traumatic brain injury. There's that concept of what's called iatrogenic hyperventilation, and that is basically a fancy way of saying we're breathing these patients down way too quick. And so therefore, obviously, we know the problems with hyperventilation in patients. So the second one down there shows basically that slow decrease in that CO2 value because we've increased our rate and we're starting to hyperventilate the patient and blow off too much CO2. So that's what you see when it comes to hypo and hyperventilation that you can trend as you're watching your capnograms while you're treating your patient. Another couple of points I want to make here real quick is that what I commonly hear in ACLS during megacodes is I'll say your CO2 value is 52. And so what they'll say is they'll be doing compressions and they'll say, okay, well, that's above 45, so I need for you to pick up your rate of ventilation. So rather than 6, I want you to jump it up to 12. And it's important that we make sure that we as practitioners and as our colleagues know that the only time that I'm looking at that is when I get a return of spontaneous circulation and you know that patient is perfusing well. In cardiac arrest, it's just a number I want to know. The higher the number, the more likely I might get ROSC with this patient versus the lower number, I may not get anything on this patient. So it's just a number. So we still want to make sure during our megacode practice or during our codes that they stay continued with that 6 breaths a minute during their megacode. And the other portion of this, when we talk about hypoventilation, are these patients that are receiving narcotics. Anytime that we are giving narcotics to patients, whether they're on pain pumps or whatever, we need to make sure that they are being monitored with capnography. It is the quickest way to be able to pick up respiratory depression in your sedated patients. So I really want to make sure that that point is driven home with you. You're administering narcotics, you need to make sure you're monitoring end-tidal CO2 as well as your pulse oximetry. All right, so some of the benefits. Obviously, verification of endotracheal tube placement, detection of displacement, detection of CPR fatigue, indication for ROSC in cardiac arrest patients, detection of decreased perfusion, detection of mechanical ventilation disconnections, predicting survival and CPR termination and resuscitation guidelines, identifying attempts to breathe while paralyzed for our practitioners who are utilizing MSI or RSI or whatever it is that you're calling it these days. And then, of course, to monitor hyper and hypoventilation in our patients. And this is just the kind of the some of the initial things. There's so much more. We talk about pulmonary embolism and some other things that capnography can help us with. But again, I wanted to pare this down to some things that we as practitioners can use right off. So going back to endotracheal intubation, we know it's the gold standard. It's very simple. Your waveform is there, you are in. If your waveform is not, you are not in. And I use that anytime I make sure that my students understand is that That's the marker. I don't care if you hear lung sounds or what you think you hear are lung sounds. If you're not getting a present waveform, you've got to question that. We know that there are other direct methods of confirmation. We talk about, obviously, direct visualization. That's also golden. I saw it go through and I've got a waveform. Boom, we're golden. Obviously, chest rise. And what's interesting is when you look at the, condensation and misting and auscultation, they may not be as reliable as we once suspected. So we really have to go back to direct visualization and the presence of waveform. And of course, when we're auscultating, what are we not doing? Really compressions. And we know that that's important, especially in cardiac arrest. You've got your esophageal devices, you've got your cap device that can go in there as well. Again, bottom line, you either have CO2 or you don't. So that is the gold standard. And here's an example where we have, we're ventilating that patient. We have a nice capnogram, and then all of a sudden it goes away. So always the question there, since it's a breath-by-breath measurement, the waveform capnogram is gone. How long do you think it's going to take for the pulse ox to change? And that right there is, should make you think, wow, I need to be making sure that this technology is used, because it may take a while for that pulse ox to change, and I may be missing an esophageal displacement. As you know, cardiac arrest, the 2010, 2015, and even the 2020 guidelines for AHA are pushing capnography. It is a standard of care, not only during the cardiac arrest, but during that peri-arrest period and post-arrest period and all of those things. So we'll talk more about that. So a little true or false question here. So the amount of CO2 excreted by the lungs is proportional to the amount of pulmonary blood flow. And I think all of you have said, this isn't a Tracy check-in question, which I'm expecting to happen anytime. Tracy?
So I got another 4 minutes, but just real fast, while we take the break for them to think about this true or false question. If you guys are texting me and answering the polls, I love it. I love the interaction, but I only need one of them. So you guys are doing great, though. Keep them coming. If you are texting me, make sure that I have your name to attach to a phone number, else I don't know who it is. So you guys are doing great. And in 4 minutes, we'll check it. 3 minutes, we'll check it in again.
Wonderful. Thank you for that. So role in resuscitation. So detection of CPR fatigue, detection of ROS, and termination of resuscitation criteria are all some of the benefits of capnography. And I think this is nothing new for all of you. So CPR and capnography, we know that the best compressions that we do during a cardiac arrest, we get between 20 and 25% of normal cardiac output. So when we talk about pulmonary perfusion, obviously it's pretty significantly decreased from what their normal cardiac output. So we know that how compressions work, it's that push and that pull, it's that positive and negative intrathoracic pressures that are experienced that push blood in and out of that whole chest cavity, including the lungs as well as the alveoli. So that's the mechanics of how CPR works. So really when we look at it, what we can see happening is that when we measure end-tidal CO2 during a cardiac arrest, what we can see happening is that when that new compressor starts, we generally will see the CO2 value go up. And it was kind of interesting that when my department first started using end-tidal CO2, as well as we started saying, hey, every 2 minutes you have to switch compressors. And I had people that when they weren't running calls, they were eating weights, and so they had muscles on top of muscles, and they were like, well, do we not have to change every 2 minutes? All right, don't laugh at me. But anyway, we were able to show them their capnograms as part of that QA debrief with showing them how their code went. So it was easy to show them after they were doing fantastic that first 1 minute. Then after that first 1 minute over, they began to show some fatigue. Maybe not physically, but something was changing in the quality of their compressions. So get that new compressor, that CO2 always goes up. So it really strongly shows the need to switch those compressors. And not only that, to focus always on the quality of your compressions as well. Return to spontaneous circulation. We're trending our CO2 values, and all of a sudden we see that CO2 value take off. Might indicate that return to spontaneous circulation. So remember that between 20 and 25% of normal cardiac output is generated by us Well, we get spontaneous circulation. That's much more blood flow to the lungs and off gassing that CO2. So be watching for that. Be careful for the administration after you give bicarb. Remember what bicarb does, how it buffers, and what does it produce? Well, it makes water and CO2. So you may get a sudden burst. If you get that sudden bicarb, you're like, well, we've done everything, so nothing else to do but to throw an amp of bicarb. And then you throw that amp of bicarb, you're like, oh my God, we got ROSC after we've been going for 75 minutes. Well, it may be the bicarbonate reaction with that. And then also remember with epinephrine, the primary effect of epinephrine is vasoconstriction in cardiac arrest. So you give epinephrine, you cause massive vasoconstriction, that obviously makes your CPR better, and your CO2 value can go up in relation to that. Termination of resuscitation. Now, here's what's interesting. I know more EMS agencies now are terminating the field, and that's great. So any resuscitation after 10 minutes shows a capnography reading of 10 or less, termination efforts should be considered. Some people use 15. They use 10 to 15 with no change. And you know, CO2 or end-tidal CO2 needs to be part of that decision-making tree. And because there's a lot of arrests that we go in on from the pre-hospital side that, you know, because of poor lighting conditions, we're not sure how long they've been down. We start working that arrest, and then we start to see, hey, we've got some lividity, or et cetera, et cetera. That end-tidal CO2 should be something to assist you to say, hey, we're done, we're stopping. And in fact, I kind of cited an article there, EMS termination, resuscitation, and pronouncement of death. And I think pretty much all the studies out there are showing that 10 or less. And of course, AHA kind of pushes that as well. So it can be something that can help you with that. To drive all of these home, when it comes to CPR fatigue, return of spontaneous circulation, etc., I think this is a great graphic that shows that. So the more output, the higher the CO2 value. So if I have bad compressions, I start good compressions, I'm going to push more blood to the lungs, and I'm going to get a higher CO2 value. If I'm doing compressions and I get a return of spontaneous circulation, hopefully I have better cardiac output with that, and I get to experience a higher CO2 value with that. So we talked about hypoventilation, you know, and again, what we have, remember with hypoventilation, the airway is patent, so the capnogram is going to be normal. So we have to look, what are the causes of those of the hypoventilation? Is it what's causing that decrease in rate? Is it a decrease in volume? You know, is it obesity? Is it use of CNS drugs? And again, we talked about that as well. Hyperventilation, again, the capnogram is normal. The airway is patent. So what is causing that hyperventilation? Looking at that, is it something that we are doing and trying to address that? Is it a pain response? Is it a compensatory response to sympathetic stimulation? Some different things that we can think about with that. Now I'm going to transition into particularly asthma. And so here's where we start to see an abnormal waveform, as you can see here. So generally with your asthma patients, you have obviously increased respiratory rate. The pattern may vary, but usually is somewhat regular as well. But notice you start to see that curvature, that loss in your initial early phases. It's starting to look like that of a shark fin. So asthma patients go through a process when they have their asthma attack. And I like to say an early, mild, and then of course an abnormal or an acute asthma attack. So what happens is, as that patient begins to have asthma, maybe they're starting to feel it and they feel it coming on, and you were to start to measure that end-tidal CO2, their respiratory rate may be going up, but their end-tidal CO2 in their capnogram may perfectly be normal. As they continue to start to have these sensations, or this feeling of this asthma attack coming on, what they initially begin to do is they begin to hyperventilate. And so again, we're starting to, the capnogram isn't really that shark fin yet, but what you see is the CO2 value starting to go down. Why? Because they're hyperventilating in this mild asthma. Now, as it progresses into moderate asthma, that's when we're starting to see the CO2 values start to come back within the normal range. And then, of course, in severe asthma, that's when we start to see the higher CO2 values. and we start to see the characteristic shark fin on our capnogram. Capnography and hemodynamic changes. You know, wouldn't it be cool if we had a tool that, you know, we'd get our patient, they have return of spontaneous circulation, and I'm monitoring this patient. Is there anything to really show me that my patient may be rearresting? And here's an example of what's called an exponential decrease in CO2. And usually you see it within 1 to 2 minutes. And when you start to see that, you're bagging the patient, you may have them on a vent, you may have your normal vent settings, and everything is good. You haven't changed anything. And then all of a sudden, you're starting to see your CO2 values are starting to go down. During that course of that treatment, you've got to suspect an exponential decrease, and that patient may be rearresting on you. Certainly, they're becoming hypotensive, etc. So again, the caveat with that is I have changed nothing in my ventilatory rate. Now, I want to look, am I hyperventilating the patient? Well, yeah, that's going to cause that. But if on a ventilator, everything is set, and I see that CO2 decrease happening, my patient is rearresting. Capnography and sepsis. So with sepsis, we use that lactate as that marker of anaerobic metabolism. Again, remember, oxygen is decreasing. Those cells are staying in that anaerobic phase, and that lactate is that marker of tissue hypoxia. And we know that the higher the lactate, it's associated with increased morbidity and mortality. So does capnography have a role? Because again, we've got this technology in the field, but do we have the ability to do lactates in the field to determine how severely septic my patient is? And the answer is yes. So there is a strong correlation when you're looking at end-tidal CO2, that if that CO2 value is 25 or less, it's strongly correlated with a lactate of above 4. And as we know, that's a pretty severe septic patient. So you can utilize that. You may not be able to measure lactate in the field, but you can certainly look at, and again, this is comparative with the patient's presentation. So you've already recognized this patient's possibly septic. You want to know how sick are they? You can utilize pulmonary end-tidal CO2 to kind of help you with that process. Tracy, do you want to interject a question here, or should I move on? Because I'm into the cases.
You have about 8 minutes, if you can give me 1 minute at the end.
Okay, awesome. So let's look at our first case study. We'll kind of go through these to kind of tie everything together that we've talked about. So you've got a 41-year-old female who presents in acute respiratory distress. The patient's cyanotic and speaking in 1 or 2 word bursts. Respiratory rate is shallow and labored at a rate of 26. Expiratory phase is prolonged. Heart rate's 142, strong, bounding at the radial. Blood pressure is 168 over 90. And patient has taken several hits of her albuterol treatment. So, you know, again, with this patient, this presentation, obviously we're leaning towards some sort of an asthma attack, a significant respiratory distress secondary to an asthma attack. So let's take a look. What do we have as we're starting to look at monitors, end-tidal CO2, and all of those things. So as we look at that, we see the characteristic shark fin. We see the last loss of that plateau there into the shark fin. Our end-tidal CO2 value is 52, which means obviously they're retaining more. So this kind of leads us in to kind of confirm our suspicion with this patient. So when we look at this, what phase then is this patient in? Are they in an early? Are they in a moderate? Or are they in a severe phase? Well, they're in that severe phase. And so we really need to think about aggressively managing this patient because they are probably fairly close to respiratory failure. So let's do that. So we've assisted ventilations via bag valve mask because the patient's obviously not breathing well. We go ahead and give our epinephrine 1 to 1,000 sub-Q and with no real quick resolution, and the patient continues to deteriorate. The paramedic prepares for intubation. As he advances the tube, the patient begins to experience a seizure and arrests. In an attempt to get the airway, the paramedic pushes the tube anyway, having to visualize the cords. And the next appropriate action would be what? So the thought here is, well, we need to check to see is that tube where it is. So that capnography needs to be right there. And so when we apply it, this is what we see. So as we look at this, is this a normal capnogram? And the answer is no. There's no defined capnogram. As a matter of fact, you can see the washout of this. This is very typical of belly placed tubes. You may get something, if they've had a carbonated beverage or something like that before, certainly not in this particular case, but some of those acids can be picked up. You can see clearly as I bagged a couple of times the washout, and you do not have a confirmed capnogram. So what should the next action be? Hopefully all of you said, well, we're going to rebag the patient attempt. So the patient was orally intubated with direct visualization. Auscultation reveals no discernible breath sounds over the anterior chest wall. Abdomen auscultation is equally silent, minimal chest rise, positive misting and condensation. And as you can see, there's the capnogram as we're working our code. So are we good? Is that tube where it needs to be? And I think everybody would agree that yes, this is where the tube needs to be. And we continue to work our code and hopefully save the patient.
Okay, Mike, we have here while we transition.
Yes, go for it.
Okay, if you're having a rating of 25, let me get back to that here. Is a CO2 less than 25 indicating sepsis? Does it equal sepsis? So CO2 less than 25 equals sepsis. Is that correct?
I'm not going to say yes, and I'm not going to say no. In a suspected, so in other words, your assessment of your patient is already leading you to believe that the patient is septic. So in other words, whether you use SIRS criteria and identify that, you look for the suspected infection, and then you have organ dysfunction. Capnography can help you with that. Once I have this patient here, and now all of a sudden, yes, they are. And so now I can use that. If that end-tidal CO2 value is that or below, it can be correlated to a higher lactate. Remember, I've got decreased pulmonary perfusion because, again, secondary to hypotension or something. So yes, but your clinical impression is already going to lead you towards that. And if you hold off, I've got a case on that.
Perfect.
We ready?
Yes,
All
please.
right. Case number two, we're heading towards the end zone here. 52-year-old male involved in a motorcycle versus pickup MVA. Patient's found unresponsive under the vehicle. You're 20 minutes from the trauma center. Rapid extrication is performed underneath the truck. The patient has a weak irregular carotid at 150 beats per minute with agonal respirations. The patient becomes pulseless and apneic. BLS CPR is initiated. The patient is should be ALS, CPR is initiated. The patient is quickly intubated with end-tidal CO2 and was moved. So before the patient was moved, you do your capnography and you see the capnogram. So as far as the airway, is it where it needs to be? We would all agree, yes, I have a normal capnogram, and that would tell me that my tube is in. You move the patient to the ambulance. And after the patient was moved, you quickly see what you see there. So what to do? And so as you assess that tube, you notice that the millimeters at the lips have not changed. And you might be able to hear breath sounds. So my hope is by somebody saying, hey, the tube has not moved. It is still at 21 at the lips or whatever. And I might hear breath sounds. Hopefully you would say, pull the tube, start bagging, and we go in again. Again, my loss of waveform, I always have to go to the tube is out. We're going to talk about the dope mnemonic and all that with the case presentation. So I've got a 12-year-old boy who presents with acute respiratory failure with copious secretions and was successfully orally intubated and placed on a ventilator. The patient remained obtundant, cyanotic, and had little airway movement on auscultation. He is sedated. There's the heart rate. Blood pressure is 138/56, end-tidal CO2 of 32. So as we take a look at this waveform, we start to see the change on our waveform, and we note a change in that capnogram. So again, we have to go back, and what does a capnogram show us? Well, it shows us airway patency. I do have an organized, what appears to be a capnogram, but I have the loss in my phases here. And so here's where we have to go back, and we have to think, that you can use that dope mnemonic, whatever, but I have to look at that and go, what needs to be done here? And so obviously with the history, if this patient has copious secretions and placed on orally intubated on a ventilator, that I've got some suctioning to do here. Again, the capnograms are there. I'm showing inspiratory restriction, I'm showing expiratory restriction, which should lead me towards some sort of an obstruction. So how do we manage that? The patient was suctioned and was subsequently given a bronchodilator treatment. As you can see now, the follow-up is a normal capnogram. So be aware of those patients that need that suction and that have to be suctioned frequently. As you suction them and you're monitoring your capnogram, you can see that change or maybe that return to a normal. And then as they need suctioning again, you're going to start to see those restrictive airway patterns, and you may want to go in and resuction that patient. All right, so you've got a 70-year-old post-cardiac arrest patient resuscitated by EMS, resuscitated in the field, transported to the hospital. No spontaneous respirations. Blood pressure is 76. Heart rate is only palpable at the carotid at 136. Shows sinus arrhythmia with multifocal PVCs and couplets. You are debating about dopamine when you start to notice a change. And what you notice is that as you're ventilating the patient at a disciplined rate, the end-tidal CO2 drops from 30 to 24 to 18. So what's going on? So hopefully you're all thinking exponential decrease. Hopefully you're thinking rats. My patient is rearresting, and begin to rapidly assess and aggressively manage that patient, because that's what you're seeing happen in front of you. You're having that cardiovascular collapse.
Hey, Mike.
Yes.
Since it's 3 o'clock, we can continue on with the case studies, but I wanted for those that need to get off at 3 o'clock, the evaluation is in the chat box. You'll also be sent a link to that evaluation form. And if Mike wants to go ahead and continue on with these case studies, we will stay on for that. And then I'd also like to say for those getting off, please join us in July for our pediatrics presentation done by Wesley Children's Hospital. So look for registrations on there. And then you can go ahead and continue on, Mike.
All right, I'll make these quick because we move through here. So a 32-year-old male patient, post-cardiac arrest, being transported on event. There's the vitals. Pulse ox is 99. Capnography is showing 38. There's your capnogram. So again, as we look at that, we've got a nice normal capnogram. We have a nice end-tidal CO2 value. As you can see, it's going to hit about 38 is what we see. And then as we're evaluating the patient, we start to see a change here. So what does this mean and what should you check? So as you look at this, again, I've got some semblance of CO2, okay? And so this is where we start thinking about that dope mnemonic, right? So I want to check that patient first. You want to always check that tube. Is the tube where it is? I listen to lung sounds, you know, what do I hear? And so what you're going to find out with this is that there was a disconnection in the breathing circuit. So some of that volume of air was actually being not picked up by the capnogram. So always think that dope, displacement, obstruction, pneumothorax, and of course equipment. So it's again spontaneously, check for those disconnections and then fix those. Real quick, you got a 64-year-old male patient, 24-hour fever, productive cough, shortness of breath, and delirium, had altered mental status and progressively less responsive to the wife. Heart rate's 162, respiratory rate of 40, satin at 90%, and that's despite 15 liters by nasal or by mask. Blood pressure is 85 over 50 with a MAP of 60, and a temp is 103, and tidal CO2 is showing 23. So this is kind of our case study that emphasizes that we should pick out severe sepsis here. This certainly shows us our SIRS criteria, and we definitely have our organ dysfunction exhibited by hypotension, DSAT, and all that. So what's going on with this patient? Well, severe sepsis. How sick? Really sick. And again, that low CO2 value of 23 can help us correlate with that lactate being high. You've got an innovative patient, 62 years old. And I want you to pay attention to this capnogram here. He received etomidate, vecuronium, and Versed, and fentanyl. You're approximately 25 minutes into the transport, or 20. And you notice that capnogram. And for the most part, this capnogram looks normal. And then you start to see a little dip there. So as you look at this, this is what is called a Curare cleft, C-U-R-A-R-E cleft. And when we think about, when we have our patients that are paralyzed, we have to think about the order of paralysis. And remember, the very first thing that comes back in that order of paralysis is the diaphragm. And so as we're ventilating our patient, we start to see those little tugs in that capnogram. That's indication that that patient's diaphragm is actually beginning to wake up, and they need some more either paralysis or sedation, whatever it is that you're going to do, whatever your protocol calls for. But that's what that capnogram actually indicates. I want you to take a look over here at the CO2 value. You'll see 32 and 82. This is actually a CPR in progress with a capnogram, and you just saw that go from 32 to 54. And again, what should that show you? That's with the King airway, and I know we didn't talk a lot about those, the alternative airways, but they do work very well with capnography, and you could see that sudden burst to 54, and of course that indicates the possibility of return of spontaneous circulation. So be sure to utilize that in your cardiac arrest. And again, with this patient here, we saw this initial EKG, a 41-year-old male patient who was initially complaining of chest pain. That's his 12 lead. Of course, we see the acute MI. During transport, the patient experiences that and what we call ventricular fibrillation. You quickly defibrillate the patient to this, and this is this. I was thinking it was chopped off. And so as we look at this, we do see a complete heart block. So you're saying to yourself, well, that's interesting. And then you begin to transcutaneous pace. So the question always is then, when I do transcutaneous pacing in this type of a patient, you know, can capnography help me when it comes to, you know, am I potentially losing actual mechanical capture? Is your patient's blood pressure falling with that? So we can use capnography. So you've got transcutaneous pacing on, you're monitoring capnography. And as you continue your pacing, you start to see this with your capnography. And again, you can see a decrease over time. And so what's going on again is that exponential decrease, and we need to check our patient and make sure that we haven't lost or losing capture, it's intermittent, or that the patient doesn't need any supportive treatment with blood pressure measure maintenance or what. This is the last one. You decided to intubate a 10-year-old. I think this is important. 10-year-old male patient, accidental OD, and are actively bagging the patient during transport. The patient is intubated with a 5.5 cuff tube, 17 centimeters at the lips. Vitals are stable, pulse ox is 99, capnography is 38. You're removing the patient from the ambulance, and you experience a cot drop, but quickly recover with no trauma to the patient. As you're moving the patient to the ED bed, the patient's pulse ox begins to rapidly decrease. It is noted to be more difficult to ventilate. What should your actions be? So here's where we start to talk about that sudden deterioration of that pediatric airway. And what could it be? That cot drop, did I lose the airway? You know, what do I do with this tube? So here's where we need to begin to use that DOE mnemonic again: displacement, obstruction, pneumothorax, and equipment. So as we use that process, capnography can kind of assist us with that. And as you are monitoring capnography, you still note the capnogram in place. And so as you further assess that, that tells you your airway is patent from alveoli to the sampling tube. So as we start to look at this, we have to go, well, displacement, dislodgement. Well, it's not dislodged because I'm getting my capnogram. It's not obstructed because I'm getting a capnogram. Again, my airway is patent from alveoli to the sampling tube. Pneumothorax, or is it equipment? So as you listen to this patient's lung sounds, you note that the patient's lung sounds are absent on the right hand, on the right side, certainly indicating a tension pneumothorax situation. What's important here, number one, is that capnography assists us with this process, but number two, we as healthcare providers, we are the number one cause, the most common cause for pediatric tension pneumothorax. Why? Because we don't ventilate enough little kids, and we put these bags in our hands and we give them too much tidal volume. And so we need to be vigilant as we look at that. We can use and very quickly assess that it is a pneumothorax and perform our chest decompression or whatever to relieve that. So capnography can help us with this. Last couple of slides, documentation is critical. You know, make sure that you're uploading your data, make sure that you're taping strips to forms and all of those things to indicate, make sure that in your narrative that you've indicated your reassessment and continued assessment of capnography through your patient monitoring experience. It's going to be very important. Lastly, if I haven't convinced you, maybe I can convince you from a pocketbook perspective. And so I just did a quick literature search and I found something for hospital as well as pre-hospital. And this is actually put up by the anesthesiology group, and it talks about this case where this plaintiff was awarded $4.5 million in judgment because of the non-use of capnography when it was clearly indicated. So that's a pretty big hit to the pocketbook. From the EMS perspective, JIMS has this capnography use saves more lives than money. And what's important right up there at that top one, settlements for injury and wrongful death resulting from undetected or misplaced endotracheal tubes are often multi-million-dollar judgments. Folks, this is a standard of care that we are being held to, and we need to make sure that we're utilizing them whenever they're indicated. And there's nothing better than to have this show up at the exchange where you hand off to the physician or to the nurses, and you're no longer in control of that patient. But also from an advocate standpoint, as you're transferring some patient care in some of these indicated situations, that you make sure that they are monitoring end-tidal CO2 on their end. So kind of coming back, did we accomplish the mission? Did we define capnography, talk about normal waveform and the phases, the indications, abnormal capnograms and what they represent, and the legal implications. So again, I hope that you found a nugget. Hopefully this whets your appetite. You know, if you're in an agency and you want us to come out and do a presentation, we can entertain that and do some little exercises and have some fun with that. So that is all I have for you today. I'll turn it back over to Tracy for final comments. Thank you all very much.
Wonderful, Mike. Thank you so much. I've already gotten multiple responses back on how awesome the staff was and how appreciative they are. If you could forward one slide, please. Again, we will do frequently asked questions that we found throughout the chat box, answer anything and give you the answers to the four that you answered. And the link to the evaluation is in the chat box and will be emailed to you tonight. And then again, next slide is the big announcement that July's learning session online will be presented by Wesley Children's Hospital and cover pediatrics. It'll be both COVID and pediatrics and also touch base on some DKA and things like that. So thank you all very, very much. And we will talk to you all soon. Bye, guys.